Well, thank you, Quinn. It's a huge honor to be here. I'm missing the in-person San Diego Shoulder Institute this year. It was just a phenomenal meeting. I'm so glad we have this, at least this going on with it. Huge honor to be part of it. Honestly, great talk so far. Grant, I mean, you and Chris Clifton, like what an amazing amount of work you guys have done. So honor for me to be here following you and Ron Navarro. I'm going to talk a little bit more on the outcomes and satisfaction piece. These are my disclosures, none of which are particularly relevant to this. I think one thing we should acknowledge is that if you compare inpatient and outpatient, the patient experience differs dramatically. The parking, navigating the facility, and check-in experience much better in the outpatient facility. And the hospital is an anxiety-provoking place. The hospital is a scary place for patients. There's the phrase for this is nosocomophobia. This is Richard Nixon, who said, if I go to the hospital, I'll never come out alive. He said he never wanted to go to the hospital. This is a picture of a building I drove by with my mother-in-law. And she pointed to it and she said to me, people go there to die. And that's how patients feel about the hospital. So when you do your shoulder placements there, I think patients feel really scared. So I think when we think about what the patients care about, they care about how are you as a surgeon communicating with them? They care, do you care as a surgeon about them? How easy was it to schedule? How comfortable am I? How anxious do I feel? How's my pain going to be managed? And you heard a lot from Ron about how to optimize that. How accessible are you as a provider? And then I think the patients care a lot about achieving their goal and having the procedure. And notably absent from this list is the things that we have at the hospital, the blood bank, the ICU, ECMO, robots, lasers, augmented reality. The hospital is not on this list of what patients care about. So what do patients really care about? And this is this great study. And if you are a shoulder surgeon and you haven't read this, I think you should read it because it's a great study that was done. It's published a long time ago. And basically what they did in this study is they provided patients coming to a shoulder surgeon with an open-ended survey of what are you here for? Why? What are your expectations for the outcome of your treatment? And then they grouped their responses. So this is open-ended. This is not like a multiple choice. They asked the patients, just tell us what you're here for. Again, then they grouped them. And these are the things that patients wanted. And the thing that's interesting about this is you can take these responses and you can actually pretty easily map them out onto the ASDS score. So patients want pain relief. So we need to get a VAS pain score. I think if you're measuring your outcome, that's got to be part of it. Patients want better sleep. So we got to measure that. Patients want improved range of motion and strength. Patients want improved ability to care for themselves with their self-hygiene and their activities of daily living. They want to return to the sports and activities that they were doing before. And then there's this desire for the shoulder to return to the way that it was. And for that, I typically would recommend this subjective shoulder value or a SANE score. It's kind of this open-ended, if a normal shoulder is 100, what is yours? And then the final thing the patients sometimes will ask for is stability. So I typically will ask for patients for whom we've performed a surgery for recurrent instability, have you had recurrent dislocations since your surgery? So for me, I will try and take these things that are grouped that the patients responded and map them out onto my outcome scores. And then if I can map all those out, I think that you have a good outcome score because you're measuring the things that the patients are expecting to achieve. And to me, that it has to be that simple. You have to match out what are the patient's expectations and then how do we measure that with our scores. So again, these are the things that I'll measure: the SSV or SANE score, the VAS, the SDSI score. I think those three outcome scores give you everything the patients expect. I think it's nice to collect a satisfaction. And then I think if you're going to do a surgery, you want to know, did I have to do another surgery? And then was there a redislocation? To me, this is 14 to 15 questions, and it can be collected in usually 3 minutes. So I think for outcomes collection, this doesn't take long, and it's not complicated. It's not a lot of burden. If you're collecting like 17 different outcome measures, I would suggest to you that you're really burdening your patients to collect information that may actually not be useful. So there's even an argument to say you don't even need the ACS. So this is a study that Keith Baumgartner published that I think it's really influenced the way that I think about it. And what he showed is that if you look at the ACS score and the SSV score, they are highly correlated. And the inclusion of the SSV does overcome a little bit of ceiling effect you see with the SES. And generally, these things are not responsive to instability symptoms. And the SES is not adaptive. So those are some problems with the SES. But there's some argument to say that the SSV may be most of what you need, and that one single question may be enough to gather a lot of information. And since I read the study, I've actually looked often at my patient's own scores, and it's remarkable how often the patient fills out the 12 questions of the SES score, and it computes a number, and the number equates to their rough estimate of, I think the shoulder's about a 40. So that's because the SES score is a good functioning score, but it also suggests that maybe the SSV is good enough. So if you're going to do the very, very bare minimum, I would suggest the SSV is the very bare minimum. So how do you actually collect this from your patients? And there's a lot of different ways of collecting it. And these have different pluses and minuses. If you're in a system that already has a specific program, you may be using that. How much does it cost? Generally, if you're not doing this, it is somewhat costly. So in 2020, I got this quote from one company. They told me it would cost about $8,000 to set up, and that the annual upkeep was going to be $17,000. So this is pretty costly, and it's hard for you to do as an individual physician. And that's, again, if you're going to use one of these programs to collect it for you. You may say, well, maybe I'll just collect satisfaction scores. And I would discourage people from relying on Press Ganey's. Patient satisfaction is kind of fool's gold. And part of the reason why is because of what we led with, that the patient's satisfaction in their experience is governed by so many other factors. There's so many things about the way in which the patient experiences their care that may not have to do perfectly with your portion of their care. Now, I think that you should work to improve all of them, but that's one reason you may not want to use this as your sole guide. So this is my personal perspective. I am doing something that is not complicated, and I learned this from Rick Madsen. He really inspired me with the talk he gave at the SES meeting about a decade ago. Basically, I have an Excel spreadsheet. So again, it's not technically complicated. It doesn't cost me anything. I will record preoperatively, some demographics on the patient, and then their pre-op scores. And so, like every day I do surgery, I make sure I have pre-op scores. If I don't, then I'll collect them from the patient in pre-op. And then at 2 years, I call people. If they don't respond, I send them a text message and an email through our system. And I'll collect what was the date of follow-up, what were their scores, and then the things I mentioned previously. Now, the thing that's nice about this is, so today, for instance, in clinic, I have a patient come back. She wants to do her right shoulder. We did her left shoulder 3 years ago. I called her 2 years. We texted her. She emailed. She didn't respond. She shows up now to the other side. I collect the outcomes today so that we still get an outcome. And that hopefully gives us the most complete data set. This has totally changed my life. This very simple thing that any surgeon on this call can do has totally changed my life. And the thing that has changed my life about is all the time I'll look at the data. I can give patients an honest assessment. When I do this procedure, this is the outcome. And I can give patients an honest assessment. This is my reoperation rate. And I can compare procedures and say, actually, when I do anatomic inverse, this is the change, the difference, the delta between them. So I highly recommend this to anyone listening. It's not hard to do. It just requires it requires a lot of consistency and organization. And that, I think, is where people get tripped up on it. But again, it's not challenging. It doesn't require anything complicated or expensive. So advantages. We standardize time points. I always call people at 2 years. That avoids lead time, length of follow-up bias. For me, my personal data provides patients with realistic expectations and allows for assessment of changes in practice. So I'll change things. For instance, I'll introduce navigation, and then I can look back and be like, how did that change things? Did the outcomes change? Did my operation rates change? And I can honestly say them. And then we sometimes have published those results. I think this is a better way of determining whether you are improving. It allows the identification of trends. So sometimes, for instance, we've published on the failure of one particular anatomic stem, identified that trends by looking at reoperations and say, wait a second, I have too many reoperations with this particular implant. I think it can provide you with solace when complications or poor operations occur or poor outcomes can occur. And this happens to everybody. But if you do an operation that doesn't go the way you want, you can then look back and say, well, what happens on average with this operation? And say, okay, well, this is one patient. Maybe it's the patient I remember, but when I look back in toto, it's 1 out of 100 and the other 99 did great. Certainly allows publication of your own success for practice building. It's focused on the patient. And as I mentioned, it is essentially free. It's time consuming, but it's free. So when I've looked at our outcomes at the U of U, as I mentioned, we collect these through our homegrown system. When I look at our total shoulders, these are outcomes for about 720 of them. And you can see that on average, shoulder arthroplasty, it works really well. The vast majority of patients are really improved by it. They have improvements in their SES pain scores and the SES scores, and they're pretty dramatic. And that's, I think, what we see with shoulder arthroplasty is this works quite well on average with outcomes. Now, if you cherry pick patients, they can look quite different. So when I looked at our data with patients that have really high comorbidity scores, they don't do as well. And certainly that's one selection bias we see in all the literature comparing outpatient and inpatient, is that the sick patients are selected into the inpatient group, and those patients do not do as well. With that being said, when I looked at all comers in my own practice and compared inpatient and outpatient, while there's not a difference in satisfaction rates, on average, the outpatient patients do have higher SSV, lower VAS, and higher ASCS scores. So I think based on this, I can really recommend the outpatient approach. It saves your patients from the fear of the hospital, which again is, as my mother-in-law says, where people go to die. And it gets your patients a consistently good outcome.